You're listening to the Physio Matters podcast in association with Choose Health, and this is session 29. Welcome back to the Physio Matters podcast. I have just about calmed down from the whole fallout from 28, as well as our special edition that we put out a week later, which seems to have gone down really well. So thank you very much for your feedback and especially for the emails and tweets and Facebook messages that have come through supporting the project and clearing up a few things with regards to the extremists and evangelists that came back at us following the acupuncture podcast. I'm glad that things have been cleared up and simmered down somewhat. My big reveal of what we call the science of sophology in the special edition podcast a couple of weeks ago seems to have opened further cans of worms, though. So I suspect that trouble in physiotherapy paradise is going to carry on for a little while longer. Not that that's a surprise, but we're going to continue to have some interesting and hopefully provocative conversations with clinicians and researchers across both physiotherapy, musculoskeletal practice, and of course we've got planned guests from all over the place. So really looking forward to continuing that. Today we have a friend of mine, I'd say close friend of mine, but he wouldn't ever admit that, Simon Murphy, who is first team physiotherapist at Leicester City Football Club. Those who follow Premier League football will know, and hopefully just sport in general will know, just how incredible the Leicester City Football Club dream has been this season. Just on the cusp of winning the title. Hopefully that will see through, or I have not cursed them. But essentially they've had a brilliant season on and off the pitch. They've had a great success on the medical department side of things too. And so it was great to catch up with my friend Simon and thank him so much for sparing the time, even in a really busy and interesting part of the season, of course, to come and chat to me about all things football medicine, as well as the particulars around hamstring injuries and management of hamstring injuries, which they do slightly different over at Leicester. And knowing how they work things, it was definitely worth sharing with you all. Extrapolating that to the clinical front line, as well as those of you working in sport, to try and take note and implement some of those things. So great insight that he's been able to share, and I'm sure you're all going to get an awful lot from it. Something worth mentioning, I think it's about 25 to 30 minutes into the episode, I think that battery started to go or something like that on the recording device, and so it started to slow us down, and we suddenly started to sound really deep voiced. Just to reassure you, we didn't both suddenly have a stroke. It does resolve itself fairly swiftly, but it's not your car or computer about to break, and it does resolve itself. So suddenly we're going to slow-mo, bear with us, and the rest of it is gold dust too. Alright, take care, I'll see you at the end. Simon Murphy, welcome to Physio Matters. I always know you as, and have known you as Smurf. I hope that nickname's infiltrated elite sports physio, and if it hasn't, I hope I'm bringing it to the masses.
Yeah, I might have to blame you for that one now.
Yeah.
No, still Simon at the minute, but yeah, I'm sure Smurf can make its way in over time. Tried my best to shake it, I must admit.
You sound delighted that I've just brought that to everyone, but okay, here we are. Would you like to introduce yourself for the listeners then?
Yeah, well, I'm Simon Murphy, or now known as Smurf, first team physio at Leicester City Football Club. Yeah, my story, is it interesting? Well, graduated from the University of Nottingham in physiotherapy, decided that football was the route that I wanted to take, where I wanted to work, particularly elite football. Gained a bit of experience at Derby County before moving to take the job as head physio at Mansfield Town, where I spent about 2.5 years, and then moved to Leicester City, where I've been since we were in the championship winning season, and been there ever since. So it's been a good ride so far. Yeah,
I know, and we're on the cusp as we sit and speak on the Thursday before the game at Old Trafford, in which you could take the title. So we don't want to preempt anything, but I think your journey is interesting, especially if you consider you were at Mansfield as a head physio as a non-league club in the season in which they then were promoted to be a league club. So really, have you known a season without a promotion, apart from obviously last season's relegation scrap? You've been a bandwagon, really, haven't you?
Championship winning, apart from a relegation dogfight. So yeah, I've been lucky so far, I guess.
It's always been exciting, yeah?
Everything's been exciting, yeah. It's always been exciting. I'm sure seasons of mid-table mediocrity are to come, though. So.
That's the spirit. Right, okay. But we obviously know each other from old, but we wanted to put this together regarding hamstring injuries and just an insight into the sports med world. And although you're not going to be giving a too much of a broad overview, we will get to the particulars. It's useful probably to open by focusing on prevention and monitoring. And so, what strategies do you put in place to minimise your injuries generally, and more specifically, perhaps hamstring injuries?
Well, first things first, it's probably worth setting the scene a little bit about why it's such an important topic to talk about. We know hamstring injuries are the single most common injury in football, especially European elite football, and we know that from the work that Jan Ekstrand's been doing with the Champions League audit. And we know that the incidence hasn't really changed over the last 25 years, which is a long time and can be quite baffling to a lot of people, certainly baffling to me if you consider the amount of money that's been pumped into sports medicine departments across elite football. And we've seen through some of Ekstrand's work that there's been a 4% annual increase actually over 13 years in this longitudinal data, which shows you things might be actually worsening slightly. The situation might be worsening. Wow. And it's interesting to focus on why that might be, really. And I mean, one of the reasons I think it may be is surrounding the mechanism of injury. Overstretch aside, which we know about, hip flexion into knee extension, that's fair enough, but it's this mechanism of injury when it comes to sprinting. If we try and break it down a little bit, where hamstring injuries might occur, if you were to look at your marathon runner, you'd probably say a pretty low risk group of pulling a hamstring. More likely to be someone who runs quickly, say a 100-metre sprinter, and then what is it about the 100 metres where someone pulls a hamstring? Well, it's rarely the start. It's normally when you get to sort of 70, 80 metres and that sort of peak speed. So we can assume it's something to do with sprinting. And if you look at the research out there, there's this theory around the terminal extension phase of the running cycle. But we don't really know what it is about that terminal extension phase, which is the frustrating thing. I mean, there's a number of hypotheses around it. Is it the harsh eccentric braking of the shank as you go into terminal extension, that hamstring working really hard to slow the shank down? Is it when the foot touches the ground, that ground contact, and you have that snap from an eccentric knee extensor into a concentric hip extensor and knee flexor? Or is it solely just the harsh load of propulsion on ground contact? So the truth is we don't really know. What we do at the football club is try and modify the risk, because we know it is an issue. And our biggest tool that we've got really is our load management.
So before we go into that, I love the fact that you've just asked about a dozen questions whilst answering that question. And I think that that's key, really, isn't it? That there is still a mystery about it. Anyone that's sort of proposing that there are really obvious solutions for a really obvious problem, you just don't buy that at all. No. And it's long gone that everyone thought it was it's got to go way back really to think that it was just an acceleration issue, whereas we find that a lot of people, they're not even accelerating at that point. They're at a plateau of pace, and so it really doesn't make any mechanistic sense if you just think about it in basic terms. So why has load management come to the fore then? Because obviously we need to manage rather than treat, rather than cure. So what's the journey in hamstring rehabilitation and treatment and assessment that's got us to a position where load management is king?
I mean, well, in football players, we know we've got a key group of players who are going to be at high risk. And we know that the main thing that we can do to sort of have a grasp of that is to monitor what they're doing through the week. And I think that's something that's developed over time. We like to think we have quite a structured week at the football club. We're not adverse to giving recovery days off. We do ask the players to work hard. For example, if you were to take a normal Saturday week in the Premier League, our players would play a game on a Saturday, have the Sunday off, come in on a Monday for an extended recovery. We know from their blood-based markers that they're still recovering 48 hours after a game. So we don't take the risk. We modify the risk and don't put them out on the Monday so they don't train. Then on a Tuesday, we'll let them go out, train, but we have some control over the sizes of the pitch dimensions, so we keep them in tight areas, don't give them the opportunity to open up and reach peak speeds. We work them particularly hard on that Tuesday, and they go into the gym afterwards, which I'll probably touch on a little bit later, and do some strength-based work. They'll have a Wednesday off to recover again because we've asked them to work hard on that Tuesday. And then on Thursday, we'll then open the pitches out. So we think they're suitably recovered. We'll open the pitches out and give them an opportunity to reach those peak speeds. One of the issues is it's fairly circumstantial. If they do reach those peak speeds, it's dependent on what happens in the game. So we offer something that we do called a Runway, which is basically just a high-speed running drill in a controlled format, which gives them a chance to reach a peak speed on a Thursday.
And so that's monitoring how much they've actually got to in a natural training environment through GPS?
Yeah, it's through GPS, but the GPS isn't downloaded until after the training. I mean, we ask the players to monitor themselves slightly, and we have people out there, and to be honest, most of the squad go through the drill. But if you imagine you have a striker like Jamie Vardy, a very quick player, he's going to reach his peak speeds a lot easier running in behind the back four in a big pitch game than potentially a centre-half might do, who hasn't had the ball put in behind him, hasn't had the opportunity to open out and reach his peak speed. We offer this drill for them to go through afterwards. And it's a simple drill. It might be 10 metre acceleration, 20 metre hold, 10 metre deceleration. Might go through it 3 or 4 times, but it's enough to get a decent amount of meterage in that sort of peak speed zone. And that's one of the things we focus on. We're a little bit different in terms of we have a big focus on the strength side of stuff at our football club. So, as I said, on Tuesdays, they'll go into the gym after the training and we ask them to lift pretty heavy weights. So they'll do an anterior chain stimulus, be it a leg press or a belt squat, and players are pushing or squatting around 500 kg on the leg. We're pushing 500 kg on the leg press, trying to push big physiological responses. And then we take them through Nordics for a posterior chain stimulus, trying to get them through heavy eccentrics. And then that's like sort of the gym-based side of stuff. And then we try and get them a functional stimulus on that Thursday. We know that we ask the players to do Nordics, and it's a slow contraction, but that's not how the muscle gets injured. The muscle gets injured fast, eccentric, high-speed movements. And that's why we ask them to do the Runway. You can't replicate that sort of fast, eccentric muscle work in a gym with any particular exercise. The only way they can do that is to sprint, and we make sure that they do that during the week.
I'm interested in the fact that they're self-monitoring that, and so you're offering that drill out and recognising certain players that might not have hit those peak speeds in a big game, training game. But that's interesting that you're not babysitting them, are you? You clearly they must understand why that drill's being offered. So there must have been an underlying education within the squad that must recognise why that drill's being offered. They might be knackered after a training session, and then they're being asked to do sprint drills, but they're the ones that can volunteer themselves for it when they acknowledge that they've not been up to peak speed. That seems like a sort of cultural change there.
Yeah, it's part of an education process, I guess. And that's something that we try and enforce in the club. The players have a certain level of empowerment to take charge of their own bodies. And of course, that's overseen by staff and monitored. And, we try and encourage the players through those drills.
Of the stuff we've already mentioned then, how does that differ from... you can't talk about clubs individually, because I'm sure that there's still an air of secrecy and mystery around some. But how does it differ, do you think, from what you're doing to other clubs, and also what you're doing now compared to historically within the club?
I'd say it's difficult to talk about other clubs. I mean, the way we approach the week is one approach. We do have a big focus on the strength training, and as I said, on that sort of functional hamstring training as well in the high-speed running drill. But it's just one approach, and the way we set our week out is a lot of it's circumstantial. It's what the demands are. In other clubs, the demands are different. Clubs will play European fixtures, Champions League fixtures, have long cup runs, have a lot more games, which will interfere basically with the structure of their week. And they have different managers. The managerial demands are different of some teams. Managers might want the players out on the pitch doing a lot of shape work, and a lot of it's low intensity, standing round, making sure you're in position. You're not getting the sort of the large training demands that you might get with other managers. I suppose that the way we structure our week is geared slightly around the way we want to play. We ask the players to work hard when they're in. They get their downtime around that. And then it's all tapered down towards the weekend where we ask them to work particularly hard. The way we play the game, it's quite fast, counter-attacking, high intensity. And they get an adequate recovery after that to make sure we're looking after them in between.
That high-pressing game that Leicester and Spurs have put into this season that's clearly paid dividends, that clearly needs to be replicated on the training pitch. And so the intimate link between game strategy and the actual training loads, I think gets ignored a lot of the time, but clearly not by you guys. There's a clear tying in between the management staff and the sports medical staff. But why has that? Do you feel that the changes in your systems are purely due to different needs, different demands, different playing styles on the pitch, or is there a movement towards injury risk mitigation because of experience over the years?
Yeah, I mean, I think any structure in any football club's developed over the years, particularly with us. I mean, we've got the head physio, Dave Rennie, who's been there for around 15 years now, and he's seen sports medicine and sports science change a lot of the years. And I guess you learn from your experience, and you learn from your mistakes as you go through, and you change your structure accordingly. We're at a stage now where we feel we've got a structure which is working to a level for us, but by no means is it a finished article, and we're always open to change and new ideas, and I think that's the way sports medicine is. You have to keep moving with it, because as soon as you stop and admire yourself, it's already moved on. Yeah,
because absolutely, you got to stay humble, stay open. I do admire your humility on the idea of it being, well, we've got one approach, but you have quite rightly been respected in recent seasons for a good injury record, and so we can't say that, well, everyone's got different approaches and everyone's equally perfectly entitled to them, and they're all just this. No, they're just different. They're not necessarily superior. Allow me to express an interest in that independently.
Yeah.
And say that you must be proud of where you've been as a department recently.
Yeah, it's been good, and I mean, a lot of the media attention that we've had, and our injury record has been pretty good this season. A lot of the media attention we've had has been around the team doing well, and I don't really buy into the correlation that a successful medical department breeds success on the pitch. I think it's an important factor, definitely, but if you can get your best players out on the pitch, you've got a better chance of performing out on the pitch, definitely. But there are other teams who might be down the bottom of the table who've got fully fit squads, and their medical departments are doing fantastic jobs, but they're not getting the results on the pitch. So the correlation doesn't work exactly that way. No. And I think it's an important one to remember. Yeah.
No, I totally respect that. But as us physios and those that are in the health and fitness industry even would watch football these days with a slightly different eye. We've got the enjoyment of the game as fans, but also then just the underlying sort of what's going on within that squad, etc. And so, without saying, obviously, Leicester's have been an incredible journey as a club this season. But independently, if we will look at the statistics with regards to what you've done with that squad medically, considering the high intensity, high pressing game that we talked about earlier, there must be an element of, I think, hopefully the world is looking on and being interested not just in what the club have done playing football, but also how you've managed that squad.
Yeah, and we do get a level of satisfaction out of that, but I mean, football's maybe a little bit different, where the stakeholders in players and injuries are a lot broader than just the medical team. We have, obviously, the players are there to look after themselves as well. We don't babysit them. We don't spoon feed them. They're empowered to take charge of their own bodies. And what's maybe a little different with the football world is that the management and the coaching staff have a big say on the loading that goes through the players. So it's about all the key stakeholders in the players buying into one philosophy. And it's been, a credit to Claudio and his staff since he's come in, that he's not tinkered too much maybe with the structure of our week and what the players have been used to, and built up a level of robustness to over the past few seasons. And I think we've probably reaped the benefits of that.
Yeah,
to a certain extent.
And to have not been undermined will stand you in good stead with the players respecting the system that has been in place as well. So that sounds promising. Now, we touched on this culture of responsibility that you seem to be describing. Staff, coaches, physios, and all the medical staff as well, having understood roles all well coordinated. Now, would you say that this is purposeful, or do you think that this is just a side effect almost of having a small department?
Yeah, it's a bit of both, really. We are quite a small department. We probably don't have the staffing levels to, babysit every single player in the gym and make sure they go through their individual prevention programs that they have before training. But even if we did have the staffing levels, I'm pretty sure we wouldn't do that anyway. Right. We try and breed an empowerment culture into the players where the players take ownership of their own bodies. Obviously, we teach them the correct techniques, make sure they're doing it properly and explain the reasoning behind the exercises we're giving them. And you might look at me and think, well, you're a lazy physio. Do you know what I mean? You need to get in the gym and do it with them. But once they've grasped it, they're all capable athletes, and all I'd become then is just a rep counter stood next to them. So we leave them to go and do it, and as long as the player's educated, then I think it makes them more efficient, and also it gives them a level of responsibility that you're not always going to be with your footballers. They're going to be away on international duty. They're going to be, have the closed seasons to themselves, and if you haven't spoon-fed them and they've got that ownership, you can have a level of guarantee that they'll be looking after themselves in the off-season as well, or when you're not with them.
I'd love to be the person that would point a finger and suggest you're a lazy physio, but of course I can't do that. But with that, I am interested in trying to parse out exactly how that might have come about, and I know that can't be done. Exactly is the wrong word, but that identity in which you're reckoning, I know what I know, and here's what I think you should be doing. This is why you should be doing it. It's your body. You've got and underlying all this is this idea that, of course, they're doing their dream job in an incredible position, regardless of how the club are performing. And so that respect across the board means that responsibility falls on them to look after themselves. And that does seem counter to a lot of things that you hear and a lot of experiences that I've had with other clubs. And so if I frame it slightly differently, if I was to deliver, I'm not, by the way, but if I were to deliver you 20 very capable physios and other medical staff that were just going to be delivered as a victory dance from this incredible season you've had, do you think your culture would completely shift? Do you think it'd be hard to find roles for them whilst maintaining that responsibility, or will they all be personal masseuses and it all shifts?
No, it'd be difficult. I think the structure that we've got at the minute works, and one of the reasons why we have a level of success is if you give the player a level of responsibility. I mean, look, footballers trust footballers, and anyone who knows or works in football will know that the players trust the footballers a lot more than they trust the physio. And if you can educate the player around what they're doing, and another player sees them in the gym doing their program, they're immediately more interested in what they've got to do and what they're doing and what their reasoning is behind it than what you've got to say as a physio.
Yeah, absolutely.
So, that player-to-player learning is an important thing, and that's a good way to sort of spread the message, I guess, throughout a squad or throughout a team in a football club. Yeah,
but if you can twist the arms of your big names to buy into what you're doing and to get results with them, then it's going to filter down into your squad and into your academies, etc.
Yeah, and it's a lot easier, I think, for players who come into the club as well to have a core structure of players who are following a certain philosophy, I guess.
Brilliant. Well, that had come to an obvious next question, really. Is there a large difference in expectations between the players, especially as you've got an increasingly diverse set of nationalities, standards, former clubs, etc.? So that it's becoming more of a melting pot.
Yeah, I mean, there's a diverse group, and they are a diverse group, and they all come with different expectations. I mean, it's important to recognise that everyone's got baggage. Be that their injury history is their baggage, or their past experiences are their baggage, or they've been injured before, their rehab experiences, or the training methods that they've had. I mean, we've had players like Esteban Cambias, who's played for some of the biggest clubs in Europe, and Jamie Vardy, who's come from the non-league, and their experiences of football are very different, and their experiences when they've been injured will be very, very different. And their training methods will have been different over the years, be that football training, what they've done outside on the pitches, or be it their gym training. Have they had that big sort of strength-based focus where they're looking to push heavy weights, push big physiological responses, get strong, get robust, get strong and long? We've seen, and I've seen when I've been to conferences across Europe, that abroad there's a less of a focus on that big strength training focus. It's more around iso-inertial type training, pushing functional movements with resistance. They're just different cultures, different ways of doing things. And obviously when you come into a new football club and, new staff, new players, new ways of doing things, there are different expectations. I think the important thing to do is build a relationship with the player. You've got to understand their past experiences if you're going to have any chance of influencing their future experiences. And you can't change everything overnight, so I guess you've got to pick your wins slightly, intervene at certain points. There's certainly been myths to be broken along the way. We've had a certain player who joined us this year from France who, had been told before that he shouldn't back heel a football because it's, really dangerous for his hamstring, and he could tear his hamstring. And it's a bit, I've seen your eyebrows just raised then, as I've told you, and my eyebrows raised as well. But I mean, this player was absolutely adamant, and you couldn't laugh it off with him and say it's a load of rubbish, because
no, it's an ingrained belief.
Yeah, it's an ingrained belief, and I think it's a good example of how much players can trust their physios and a sort of level of responsibility that you've got as a physio to what you're telling to your players. And there's been myths that need to be broken along the way, and I guess it works both ways, really. It's all a learning experience. And, I would never say that new players won't come in and show me things that I think, well, that's really good. I would have never seen that before. That'd be something that's really good and we could put and implement into our structure that we do at the minute at the football club.
Right, okay. And so, although anyone that knows you, and hopefully the listeners now, we're 20 minutes in or something, will understand that you're an able communicator that can engage with a conversation or a topic really well, and that's I hope a real talent of yours. But in doing so, is it fair for me to say you're going to use that ability to communicate to engage with that person and tease out those expectations, those beliefs as early as you can, to see how they're influencing their behaviours and how they're going about both their training and in terms of their health?
Yeah, I think the communication factor is key, and there are challenges along the way, particularly if you've got players who don't speak a lot of English. Then you really are testing your communication skills. Mm-hmm. But you need to be able to get your message across, and I've certainly learned that you need to get it across in a way that isn't, ramming your method down a person's throat with a total disregard of their past experiences and their past methods. Because, I mean, we all know with physiotherapy that there's a lot of different ways to go about rehab. And who's to say that these players that we've had before have had injuries in the past? They've obviously got better through whatever their rehab techniques have been. Yeah. They're obviously with us now, fitting well. So in their eyes, they probably can't see too much wrong with what they've done.
Yeah, absolutely. So respect of that is key, and then trying to move them towards a direction of more sensible travel, I suppose, is the key one. So we're best, as much as you're right, I think the setting the scene around all that and the prevention of things are in and around load management doesn't have to be independent to hamstrings. But let's go towards hamstrings more specifically then. And can we talk about differential diagnosis briefly? So player pulls up, clutching posterior thigh, as we said, in that high speed situation at peak speed. I'm putting good money on it being a hamstring injury, but what could we be missing if we assumed all posterior thigh pain to be hamstring specific, which is a mistake that is seemingly made, not necessarily in football, but in the sports med sector. It just seems to be an impulse sometimes.
Yeah, I mean, less so in football, I'd say, and we're lucky in football in the sense that we're often there at the time of injury and we've got replays. So the mechanism of injury is always key. And we are lucky in football in the fact that we get to see that and we get to see it again and again on a replay.
Is that just for wincing purposes? Or
no, probably not wincing purposes. Purely professional purposes. But if you, if you weren't to see the mechanism of injury, I'd advocate that it's pretty important to get a really good description of what happened. Was it high speed running? I mean, if you know it's starting to take you down the line, that it's a biceps femoris long head injury 95% of the time. Is it an overstretch injury? If it is, then if you believe some of Askelling's work, then it's probably going to be a more proximal related injury in the semimembranosus. And for me, I'd get a good description of what the body position was at the time of injury. It's important to know what position your patient or your player's tied himself up in, because it'll give you a good understanding of what's going on in terms of differential diagnosis. Now, if a patient was to come into me in a private practice, the first thing I'd want to rule out is a discogenic pathology. And I do that using my red flags. But the likely other suspects that you're looking at really are predominantly down the neurogenic route, be that sciatic symptoms, piriformis syndrome, a neural grab at the back of the hamstring. We've had one particular incident this season in a game, a Premier League fixture this year, where one of our players has flexed his hip, extended his knee, dorsiflexed his ankle to try and reach a ball high as it's coming down, and basically tried to header the ball as well, and found himself in a glorified slump position. This player, he'd never pulled his hamstring before, so couldn't differentiate between the pain, has just felt a pain in the back of his thigh, clutched his posterior thigh, and that's him. He's coming off the pitch. Do you know what I mean? He thinks he's pulled his hamstring.
And so does everyone else.
And so does everyone else, yeah. And he thinks he's, all he's had is basically just this big neural grab, which is a shock at the back of the hamstring. And, it doesn't feel right straight away after you've done it. You're aware that something's happened. He's come off the pitch. We've assessed him, can't find anything, MRI'd him, grade 0 hamstring. 5 days later, he's back playing, 6 days later, he's back playing the next Premier League fixture. And, we're getting praised in the press for turning around a hamstring in 5 days, and also, also people calling out saying Leicester City must be doping because this player's come back from 5 days with a hamstring. He's never pulled it, and I guess that's one of the issues that you'll have in football, is that everything you do is played out in the media to a certain extent.
I imagine that's why your hair continues to be immaculate, constantly on the cameras.
Yeah, I think that's important, Jack. As do you, with those spikes.
Oh, of course, yeah. 90s boy band spikes. You've got to keep appearances. So carry on with your differentials then in and around that area. So what else are you keeping an eye out for?
Following on from neurogenic symptoms, you'd be looking at the potential of a lumbar facet problem, irritating a nerve root, which could be having an effect. And you can look at the sacroiliac joint. I mean, it is something that we assess, but not necessarily something that we prioritise. And then you can move further on to things which are maybe a little more specific to football, be that DOMS, which, players can get post-game, where they've got symptoms in the posterior thigh and they want that clearing before they go out to train. Or cramp, which just happens in the game, and that's something that we can try and modify slightly with supplementation, like quinine sulfates.
Okay, and you had an incident in which player pulls up with cramp. I imagine you'd get similar sorts of things that happened with the sort of neural stinger almost.
Yeah, we've had a situation this season where one of our wingers had been running down the wing, high speed running, grabs the back of his posterior thigh, stops.
The world says hamstring.
What
do you say?
Well, I say look at him for a little bit, see what he says. He says cramp and carries on playing, and there you go.
Okay, no problems.
No
issues.
No, played on for another 10 minutes, and then there was a tactical change which brought him off. It just so happens sometimes in games, obviously football games are circumstantial, so the amount of high-speed running or very high-speed running that you do is a lot dependent on if you've got the ball, if you haven't. A lot of it's circumstantial, and if a player in a particular game has done a lot more high-speed running that he might have done in a different game, often happens away from home, they're more susceptible to cramp.
No, fair enough. Now we're not going to prioritise it, and we're going to get on to the really juicy stuff regarding hamstring rehab in a second. But with regards to pelvic alignment that you mentioned, SIJ, that sort of thing, if we tease out some of the things that you do assess and look for and deem relevant, and how you then present that to the patient or the player, what's the sort of drill with that? What's your reasoning in that?
We do look at alignment of the pelvis as a factor, and I think what differs in football slightly is that we are working with fairly finely tuned athletes who know when something's up with their body, so they know when a particular hamstring is feeling tighter than the other side. They're a lot more aware of themselves, and often when we do look at them, there are malalignments in their pelvis when we do assess them.
And by that, you're meaning objective measures of leg length, rather than a motion palpation sort of sense?
Yeah, just objective measures of leg length, and then will we treat around that to reassure the player? We do treat around that Does the player feel better afterwards? Often he does. And for us, to a certain extent, that's our job done. We've sort of done our bit there because they can go out and train, and we don't get overly bogged down with putting a particular label on it, I don't think.
Right. So what are you telling the player there as you're assessing and treating it?
But we're not putting labels on the players. We're not saying that they've got an upslip per se. All we're doing is we're looking at them saying, and they do, in a lot of cases, have localized tightness or tonal changes in a certain area, which is correlating to what we're seeing. And by us treating that locally, we allow the player to feel more comfortable, reassured, able to go and train. And we're quite comfortable in doing that, I think.
No, fair enough. Now, we can get onto the some of the juicy questions then, really, as to the finer parts of assessment and management, as well as then the meat on the bones of the rehab. So how relevant, say, is the size of the tear at the point of injury? And therefore, what's your assessment and imaging protocol for when someone does then have a hamstring injury and we've cleared all the other differential diagnoses?
Yeah, I think the size of the tear is relevant in terms of what you're going to see. And for us in football, we're lucky again because we can see the player straight away. So for a grade 1 tear, we often see a player having a bit of a feel around the posterior thigh, not able to pinpoint exactly where the area of pain is, but contractually they know that something's not right and their gait isn't particularly affected. More likely for a grade 2, they're walking with an antalgic gait, refusing to walk into terminal extension, and they're a lot more specific in where they pinpoint their pain to be. And then for a grade 3, for a footballer, they're often being stretched off the pitch.
Right.
And for those working privately, I suppose it depends how acutely you see your patients as to what you're going to see when they walk into the practice. For us, one of the key things that we have is players' past experiences, so they know when they've either pulled a hamstring, if they've done it before, they know what that feels like. And I think you've seen on the telly when you see players who've had recurrences of injuries in the past, they're completely dismissive. They know exactly what's happened. They're not interested in an on-pitch assessment. They get up and they walk off.
They storm off, yeah.
Yeah, and players know their bodies best, so it's important to trust what they're saying. We certainly find that.
And I'm into that, and I'm into the trust culture that you're describing. However, someone's had a grade 3 hamstring before. 3 seasons on, they pull up and they've had, let's call it radiographically, they might have had a grade 1. We can understand through how these things can manifest is that they might, because of their previous experience, they might hobble off as if it's a grade 3 again. Do you see what I mean? In that those presentations can sometimes be misleading because their body's gone into a protective overdrive where it feels familiar and they're just associating it must be as bad as it once was. So to some extent, although we can trust them, that we can't always trust the intricacies of their subconscious, can we?
No, and I'm not saying rule out an assessment completely. Of course, we assess our players. When we get them in, we normally have a baseline assessment of their range of movement, and then we won't retest it again after that. And the range of movement will guide us slightly as to what grade we think the injury is. Right. And then we won't test because we don't want to stretch this tear again after the initial injury. And then we'll do a contractual test, normally isometric based in various ranges. And only if I was really struggling to clear a player to go out to train would I do then an eccentric through range test, basically just to reassure the player and reassure myself that there isn't anything structurally wrong with that hamstring. I mean, from your assessment, you want to be able to try and establish what's going on in the muscle. You're going to have an idea that it's the biceps femoris which is involved because 95% of the time that is the muscle that's injured during high-speed running. And then you want to get down to the specifics of what's going on in the muscle. And to do this, we tend to get an MRI. You want to know, is it a myofascial strain? Is it proximal, distal, in the mid-belly? And you definitely want to know if there's anything going on with the central tendon inside the muscle. We know that the tendon takes longer to heal than muscle, so it's an important thing for us to know. There's been some work done by Rod Whiteley saying that, you know, with an MRI you can't predict return to play times for hamstrings, and I completely agree with that. You wouldn't be able to predict them, but it can certainly guide you as to your rehab and your healing times. So it's something that we do. We know we're going to need to give the tendon more time to heal if it's injured, and the issue with the tendon is that it can start to feel pain-free after a couple of weeks, and you won't know that there's something wrong to it until you expose your player to those high speeds, and that's when you're going to start to get issues.
No, that totally makes sense. And so what about what's your frequency for re-imaging then? So you image as soon as you can do an MR, and then are you monitoring that with repeat scans? Are you doing any diagnostic ultrasound on that through that process or not?
No, we tend to just image the once at the start, and that'll give us the baseline to work from. And then from that, we should be able to build a rehab plan, which will take us back through to return to play. The only issues that you might need other intervention in is if the central tendon is damaged to a level where on the MR it's looking wavy, retracted, it's lost its tension, and then you're going to need to have a look at getting a surgical consultation. We do certainly anyway for our players, because we have players at our club who rely a lot on their speed, and it's going to be a factor which is potentially going to be lost unless you can restore that tendon back to its optimal length, which is just natural physics for force production.
Yeah, of course, you can't ignore. We'd love to use the term adaptation, but sometimes there is a threshold, and we need to restore the morphology. What's the drill with that threshold, though? Where's the line as to whether to get a surgical opinion or not? Is that just an imaging thing, or is that recognising the player, their position, their style of play as well?
Yeah, I think it's a bit of both. I mean, what the player will depend on. If you've got a player who is a winger who relies a lot on their speed, then it's definitely something you want to look at. But for the most part, I think it's worthy in football getting a surgical consultation anyway. You want to do the player the best service that you can. And if this injury is potentially going to have long-term effects, if the tendon's damaged to a certain extent, then it is going to affect their force production. It's only fair that you take them to see a surgeon to see if there's a way of correcting that, basically for their long-term future. And it's an analogy that makes sense in terms of if you imagine an elastic band and a slingshot, you're going to want a nice taut elastic band to get the force production out of rather than a baggy one.
Mm-hmm. Well, that's reasonable. Now, that I imagine you're not getting a surgical consult for all your grade 1 and 2 hamstrings, though?
No, they tend only to be your more severe grade 2, 3 hamstrings.
No, fair enough. Now, in terms of the rehab process, if I can allow you to wax lyrical on that in full. So, from the start, what's it looking like at Leicester City right now?
Well, at Leicester we follow a philosophy which isn't overly complicated. We have a graded approach, tick the boxes that need to be ticked, and don't have any major jumps in load which might surprise or overload the healing tissue. If I've got a player who's at the minute injured and can only walk at 2 kilometres an hour, but I know his top speed's 35 kilometres an hour, I need to get to that speed for him to play on a football pitch, but I need to get there in a safe way. So we take the philosophy that the hamstrings are self-limiting muscle, really. It'll tell you when it's ready to progress through what it's feeling. And with that in mind, our hamstring protocol is pretty much player-led and a guided discovery for the player. We use the treadmill as the main focus. We get them moving for our grade 1s anyway, pretty much straight away. And we ask them to work in pain-free ranges without any NSAIDs to mask any of that pain. And we find on the treadmill we can allow for a controlled elongation of that healing tissue through a gradual eccentric loading. Using the treadmill, our philosophy is objective and it's controlled. And we try to just utilise normal movement patterns really as soon as we can, with an aim to reduce any neuromuscular inhibition. So if you imagine you have an injured player, grade 1 hamstring, day 1 post-injury, we'll get them on the treadmill and we'll get them walking. We want them walking up to a speed of 6.5 kilometres per hour when the hamstring lets them reach that. And in a day, they'll try and do 2-kilometre runs, but they're essentially walks, to try and initiate those normal movement patterns. Alongside this in the gym, the strength training focus, I use strength in inverted commas, it takes a bit of a isometric focus. It's more about maintaining activation and decreasing neuromuscular inhibition. And we focus on the glutes and the hamstrings. We know we're not going to hurt them working them isometrically, so we can get them going in that sense. And we try and maintain movement in the thoracic and lumbar-spinal levels just to try and stay on top of any neural symptoms early. As soon as they're able to get up to 6.5 kilometers an hour, which is basically a walk breaking into a jog, we move them on to phase 2. And we want them to try and achieve 14.4 kilometers an hour for 2 2-kilometer runs. So we're asking them to work a little bit harder now, and we're asking them to run, basically, when that hamstring's allowing them to run. So as soon as it tells them they're ready to, as soon as they're not getting any symptoms, they're running, and they're running at the speed which the hamstrings tell them they can run at. The gym work takes a little bit more of a concentric focus at this stage. We'll be doing hamstring manuals through range, hip separations in line, and bent and straight leg swing throughs as comfortable. So all comfortable ranges, nothing which is going to irritate the hamstring. And we try and get them up to this 14.4 kilometers an hour, which is around 4 meters per second. Now, it's worth mentioning that we grade everything with GPS because that's our way of measuring training load. So we know speeds that players can get to. We know their peak speed. And if we know their peak speed, we can gradually build up towards it, engage through speeds on the treadmill, what rate they're running at.
Because that's it. This isn't actually, although there's a lot of stats and thresholds there, these are individualized. They're not necessarily generic. You know, you can make some best guesses on averages. However, you know where someone's individual targets are.
Yeah, we know what speed on a treadmill will correlate to what speed someone runs outside. And all we try and do is utilize a stepwise manner to build them from that walking slow speed of being injured to that return to play speed. So if I was to move on to phase 3, at this phase we'll take them off the treadmill, maybe take them inside the gym into the functional area and ask them to do a really low level ladder progression drill, which is low speed endurance, trying to fatigue that muscle bridge down, fatigue the muscle down, see if we get any symptoms. Is the muscle that's healing basically tolerating with the load that we're asking it to do? And if it is and we don't get anything back, then that's great. We'll put them back on the treadmill and try and get them to run 1 kilometer at 16.5 kilometers an hour, pain-free.
Right.
And that's basically equates to 4.5 meters a second on our GPS, which is a high-speed run. Mm-hmm. So we'll ask them to do that on the treadmill, and the strength training work in the gym then takes a little bit more of a concentric, eccentric focus.
Right.
The eccentric load we'll still monitor, so it's nothing too heavy, but we're starting to just get the muscle to work in that particular way.
What did you mind if I ask, what sort of, just a couple of examples of exercises that would sit within that grade 3 sort of bracket? What sort of things do you do in?
We're starting to take them through fairly low weight RDLs, hamstring calf pull throughs using plyo box and a TRX band, Swiss ball rollouts, working concentrically and eccentrically.
Right.
And you can work the hamstring manually as well with the therapist.
Yeah, of course. No, it makes sense. No, that's great. And does that box off the sort of grade 3?
Well, the final bit to tick for us really is we ask them to then repeat that 1 kilometer run that they do on the treadmill, but we ask them to do it outside.
Right.
So we take them off the treadmill, put them outside, ask them to repeat that 4-minute high-speed run. And we know from pre-season data where we've asked them to do that run before that they're going to be averaging out around that 4.5 meters a second. We just know that we're going to be asking the muscle to work a little bit harder because now we've changed the surface and they've got to propel themselves basically outdoors. And that'll sort of tick off the phase 3 for us. As we move on to phase 4, we're happy now that they can achieve 4.5 meters a second pain-free. So we take them onto a treadmill overspeed program where we're basically asking them to reach speeds from 16.5 again, working 30 seconds on, 30 seconds off 6 times, up to 18 kilometers an hour, and then 19.5 kilometers an hour. So 6 reps of 30 on, 30 off at each of those speeds as a gradual way to build up to 5 meters a second, then 5.5 meters a second. The strength work in the gym will then take a little bit more of an eccentric focus solely. So you're now moving along towards your Nordics. We're still potentially not ready to do full flat-out Nordics, but we can certainly band assist them,
right,
and give them a little bit of support as they work through those ranges.
Yeah.
But with the treadmill-based stuff, they're the speeds that we're looking to work at, and we're basically asking the muscle, can it increase the rate of force development now as we bring the speed up? So we're challenging that healing muscle. And then that's basically our way of bridging the gap between being on the treadmill and taking them outside to ask them to do more specific stuff, which will take us on to the 5th phase. And what we do here is we tend to revisit the runway work that we spoke about, that we use as a prevention tool as a risk modifier as part of a normal training week. What we do originally is we'll open the runway out, so it'll be 20 meters acceleration, 20 meter holding phase, and a 20 meter deceleration phase. And we're trying to just challenge the muscle now. Can it ramp up the speeds? Can we start to work towards 8 meters a second in that holding phase? And we give them a big gap to build up to it and a big gap to slow down from it. And then all we do is we gradually pinch it in from each end. So we'll bring the size down, so it'll be a 15 meter accel decel, 10 meter accel decel, 5 meter accel decel, and you're gradually just challenging this muscle to push the rate of force development, push the rate of torque development in a gradual manner as you get those harsher accelerations and decelerations. And we can measure with our GPS what speeds we're getting them up to. And as soon as we can get them up to within 90% of what we've got them recorded as for their peak speeds in their runways or in training in general, we know we're in safe limits to let them back into training, because we know when they're challenged in training to reach a peak speed, they've already cleared it, so they've got the ability to do that. Of course, there are other things to tick along the way before we return them to play, which we push onto in the next phase. But that's what we're looking to do with those runways in phase 5.
In phase 5, would that how would that correlate with the rate of force development on a cut, for example? So we're dealing with something quite sagittal, quite linear at the moment, I imagine. But to return them to training, even at low grade, would involve some more twisting and turning. Does that seem to not be as big a factor because it's not relevant to the mechanisms of injury, or is that just something that comes with the training and you can let them get away with that?
Yeah, I mean, the runways are a key part of what we do outside, but they're an adjunct to what we do. So as soon as the players go outside, we'll be doing position-specific movement work with them. They'll be doing ball work. They'll be doing overhead clearances. They'll be cutting. We'll set up sort of functional drills specific for their position. So they're replicating movements, and we know we can clear them in that aspect before we put them into training.
So it's all alongside it.
It's part of that. I'm just trying to give the overview of the flavour of the main boxes that you need to tick.
You're absolutely right. I'm just thinking, in my head, I already had a ball at their feet in other parts of their rehab.
Yeah.
And I just wanted to make sure that I wasn't on the wrong lines. No, that's cool. So then, we're into the latter phases then. So where are we up to?
Well, the final phase is that they return to protected training, basically. And for this, you need a good relationship with your coach and your management. And you basically pick and choose parts of training that they go into, pick and choose parts of training which you're happy for them to do. So for their first training session back, you might be happy for them to get involved on a Tuesday where the pitch dimensions are small. You know, we're going to work them, they're going to get a heart rate response, but we're not going to expose them to those peak speeds. We can wait an extra couple of days till the Thursday till we do that. I suppose it depends what day you put them back into training, but we can tailor what they do. So it's modified training, it's protecting training, it's modified risk, and that goes all the way through to the game. We make them available for the game, but then we can modify how many minutes they play as well. It's all about minimising risk.
Absolutely. Now that level of tinkering when it comes to load management, it's just completely rational, reasonable, certainly evidence informed, but also practical based on your data from seasons before and others that are contributing to that literature. But there is a world of functional tinkering, and I hate the fact that word's been butchered, but how much do you interfere with people's biomechanics in this process? How much are you looking at the intricacies of their force development in different muscles? I've seen players rigged to a dozen therabands and all sorts of other things, EMGs all over the face. You know, I'm obviously exaggerating, but you know what I'm getting
slightly,
at.
Yeah.
You know what I'm getting at.
Yeah, I mean, we keep it relatively simple. I don't profess that it can change a player's biomechanics, certainly with anything I could do with my hands, and their biomechanics have got them so far that they're at an elite football club playing Premier League football, so who am I to then tinker with their biomechanics? I think the important thing for us is to understand what is clean movement for that player, and when you're working with a group of 25 players in a squad, You see them train most days, you see them play games, you understand what's clean movement for them, what looks right for them, and as soon as you know what looks right for them, you can start to identify what looks wrong for them. So when you put them into modified training and you're watching them train, you can assess their accel decel profile. You can see, are they skipping out of decelerations? Things become a little bit more obvious if things are right and things aren't right.
And these are very well videoed athletes. There's plenty of material to touch on to try and work out
we've always got a video camera out.
Yeah.
The important thing for us really is that peak speed is what we sort of hang our hat on to allow someone to go back to training. We know that they can reach that peak speed, but it's what's relevant to your environment. We know that they need to be able to be running at that speed to deal with the match day demands. If you were running in a clinic, you might want another return to play test that you'll hang your hat on. For example, we don't do the Askling H test because we don't feel we could hang our hat on that and then return someone to play. But if we can get someone running up to 9.5 meters per second with no issues repeatedly, then we know that we can put them back into training.
So what else is going on alongside all this rehab then? Tell me about what the profile is of your typical time spent with these players.
Well, we've mentioned GPS already, and that's something that we have the players wearing from the start of the rehab process. So as soon as they're on the treadmill, and you might be thinking, what's the point in having a GPS unit on a treadmill? They're not moving anywhere. Well, we can actually extrapolate some fairly interesting data from it. Even though they're not moving anywhere, we're giving them set workloads, so 2-kilometre runs, a 1-kilometre run. And we can see how well they're dealing with that set demand through the data that they give back, be it how many strides they're taking to complete that set load, what their left to right discrepancy is whilst they're completing that particular task. So it's information which is of relevance to us because we know that during the rehab process they're going to be repeating these tasks a number of times through until they reach that pain-free final speed ticket and move on to the next level. The GPS is also valuable for us. Obviously, when we take the players outside, we can get a measure of distance, so how hard we're working the players and at what speed zones we're working them, how many accelerations and decelerations we're having. And it's also the key one for measuring that peak speed, so that maximum velocity. It's all part of an education process, really, which happens with the players, the whole MDT. We have really good sports science staff who will extrapolate the data and put it in beautiful graphs for us to actually understand. And the players see that data and they get talked through that data. And we try and educate them through the process because, as we mentioned before, players trust players. Other players are going to get hamstring injuries. We want them to be able to talk to other players, talk about the process, what their experiences were. And it all helps towards a reassurance process, I guess, of people going through that process and knowing that they've come out the other side of it in reasonably quick time without any issues.
Yeah, okay.
Touch wood.
No, brilliant.
Other things that we've got, I mean, we do Nordics. We do Nordics and we have a Nord board. We know from some of the data, obviously, that's out there that, Extrand will tell us that Nordics aren't commonly done in football. Well, we do them. The way we do them may differ slightly. I think we probably adapt our reps and sets compared to others. We use them as a prevention tool, as I mentioned earlier, on a Tuesday, and we'll use them as a rehab tool as well as we go through as a mean for eccentric strength. I mean, some of the literature says that you'll do five sets of 5 reps of Nordics, like absolute savage amounts that our players just wouldn't be able to deal with. I think what you need to do is lean on what evidence is out there and see if you can tailor that to your particular field and what's suitable for your players.
Because that's a question within that I had, and I know a number of other members of the team had when we were putting this podcast together, was why the rationale for absolutely exhausting the hamstrings in season just doesn't seem to sit well with my hunches. Now, of course, we want to have robust tissue and neurological tolerance to these movements, but to do that would seem counterintuitive. And so you've decided to, although integrate it, you're not necessarily putting that at the centre of what you do.
No, but I will say it's a key part of what we do. It's a key part of our sort of posterior strengthening program on Tuesdays, and it's a key part of our rehab program. The thing about Nordics is we certainly feel that it's one of the few things out there with any shred of evidence to say that it can decrease hamstring injuries. So a certain part of us, it's a little remiss of us not to offer it to the player if we know that there's got that evidential backing behind
absolutely,
it. Yeah. And we've got a Nord board, which, the guys in Australia, Anthony Shield, David Opar, Ryan Timmins have worked on. And we find it's useful. Players like numbers, and it's a way for us to objectify maximal eccentric strength. And by objectifying it, we can show improvements in it. And we use it every Tuesday. Our players will come through and have an eccentric hamstring stimulus on the Nord board. The reps and sets, it's more like one set of 3 reps, maximal effort at the end of training once per week. But it's what suits your environment, I guess, to a certain extent.
Okay.
We actually, through our longitudinal data, which has come through the season, we've seen that our players are getting stronger. The more they do the Nordics, we've seen improvements in strength, and we've seen that any asymmetries that you find on the Nord board are starting to marry up a little bit the longer they've been doing them. The asymmetries are coming a little bit closer together. Of course, it's purely anecdotal data at this stage. It's just our personal data that we're taking. I get it. I get the Nordic naysayers out there who, say there's a really small evidence base and, it doesn't work the hamstring through the full range. I'd argue you can work it through full eccentric range if you band assist them and give them a little bit of help through that range. And there's people out there that says it reinforces asymmetries, but I don't completely.
You're not seeing that. Yeah, but then what about the flip side then, that it is the magic bullet and that it needs to be integral to everything? Is that pushing that? That seems to be pushing it too far, right?
Yeah, well, that's physiotherapy in a nutshell. Nothing in isolation. There's not anything in isolation. If you try and take any modality in physiotherapy and use it on its own, I think you'll struggle most of the time.
Yeah.
It's not. We don't take that approach. It's nothing in isolation. It's just I suppose in football, what you're looking for is bang for your buck. You've got a limited audience with these players. They're footballers. They want to get in. They want to get off. They want to get home. What can we do which is quick? It's got some evidence behind it, and it's what you're seeing results with. If you look at some of the work that's done out in Australia by Shield, Opar, Timmins, they've put people in MRIs after they've done a Nordic, and basically found that semitendinosus and gracilis are the muscles that light up like a Christmas tree with that exercise-related T2 change. So it doesn't even work the muscle which is most commonly injured in high-speed running, but it does beg the question, what is the relationship then between Nordic as an exercise and hamstring prevention? And there was a nice study done by Shermans in 2014, it was, the Biceps femoris and semitendinosus teammates or competitors paper, and they basically follow the route that biceps femoris and semitendinosus do have a complex synergistic relationship, but what they found is the semitendinosus has a lack of endurance capacity, and when that endurance capacity starts to fail, it's biceps femoris which picks up the slack. And they found that it's previously injured athletes who have that decreased endurance which puts more demand on the biceps femoris. If you look at endurance in that muscle as a modifiable risk factor, we know we can't affect age, we know we can't affect previous injury, but we can affect eccentric strength. Potentially we can affect that endurance, and if the Nordic hamstring trains that endurance, then maybe that's one of the reasons why people are having some success, or there is some evidence linked to reducing hamstring injuries with Nordic exercises.
No, it's interesting. I mean, there's a number of things we can sort of postulate, but few answers at the moment.
Yeah,
but that certainly makes sense. And so, if you're happy to, we're already talking around the dirty word that is adjuncts. And so, what else is going on alongside all this? So we're still within the remit of strength and conditioning, return to play regarding exposure as being the primary sort of care modalities. Yes, the GPS is an adjunct. Yes, we can have a look at that and scrutinise that. Education comes into it. What about the other stuff? What about the electrotherapies, the manual therapies, the other things that you're doing more passively or collaboratively with the athlete?
Yeah, we're lucky in the sense that we have players for a protracted period of time at a football club. So they come in injured in the morning and we have at least 4 hours to spend with them. So we're in a position where we can explore different modalities. We've got the time to treat the patients. We're not in a position where we have to prioritize, I guess, particular modalities over others. We can treat the players accordingly as we go through. So we do electrotherapy, we do manual therapy, we'll do soft tissue work around the area, on the area. Electrotherapy is definitely something that we do.
Okay, so what is it about those treatments, electrotherapy, manual therapy, that you're describing, that you feel that they do, that they bring to your bigger picture and to the management of those athletes?
Look, for us, the bigger picture is that we need to show the player that we're doing all we can to get them back on the football pitch. Does that mean that sometimes, we'll do electrotherapy even though there's limited evidence behind it? Yes. Do we do soft tissue massage around the area and there's limited evidence around it? Yes. Do we do acupuncture sometimes and there's limited evidence around it? Yes, we do, but we need to give the impression to the player at least that we're doing all we can, maximising our time with them to give them the best chance, be it through psychological benefits or physiological benefits, to speed their recovery up as much as possible and get them back on the pitch.
And what's your go-to line when it comes to the line that often gets asked, which is, what's this doing then? So they're sat there with a machine hanging over them, pulse, shortwave, ultrasound or otherwise. What's this doing then?
Well, whatever the modality, we'll always explain what the evidence is and leave it with the caveat that, but of course, the evidence is limited. And if they attribute themselves getting better to that modality, then that's what happens. We don't ram it down their throats.
Do you find that they do attribute success of their recovery to these things over the brilliant evidence-informed examples that you've used throughout the rest of this podcast?
No, I think it just forms a battery of treatment modalities that we use, and they attribute the whole process probably to them getting back together. I know I've got scientific backing or anecdotal backing for some of the stuff that I'm doing, but the end product is, and what we never lose focus of, getting the player out on the pitch, getting them playing. When it comes to me going into a manager's office and telling the manager that, a player isn't fit to train, I'm not going to get bogged down in the semantics of, well, I'm currently engaging in electrotherapy and acupuncture with them at the minute. They don't care about any of that. They just want to know when they're back, fit, ready to train. No,
fair enough. And so as a mechanism, you're just feeling that is a pain relieving process for that athlete in order to facilitate them training. You're not necessarily saying you're not purposefully interfering at certain times with certain modalities as a means of enhancing their physiological recovery, as much as you are saying that you're doing it as a means of monitoring their pain relief and their ability to train.
No, more along a global reassurance, I'd say.
Okay, so you're acting on that, like you said, doing everything you can at that moment in time. Now you mentioned
and letting the player know we're doing everything that we can. At that time,
and the club maybe. So the club sees that you're doing everything you can.
Well, club less so, because I think we're in the medical department entitled to make our own decisions on how we treat the players. But if I was to say I'm only going to do treat players with things with really hard evidence backing, the player could come in, I spend 20 minutes with them, and the other 3 hours they're sat around because I haven't got a paper that says I can do this particular modality or that particular modality.
No, it's fair enough. I mean, I can tell from the smirks and scowls that you think I'm being heavy on this question, but you mentioned about we've got the time to spend, that we don't have to prioritise one over another. Now, I would question that, because you've landed on certain modalities there that, yes, evidence is mixed, the jury's out on certain things, some of which we've discussed at length on previous podcasts. However, you're not sitting down with a player and going over their horoscope to suggest that might be an influence. You're not necessarily tickling their feet and calling it reflexology. You're clearly comfortable probably to say that doesn't belong in my medical department.
No, I think
so what meets the threshold?
It's what sits well with you as an individual, I think, with you as an individual physio. Right. You have to lean on what evidence is out there and form your own opinions, and I think all physios have to do that. All physios have to form their own opinions. There is no set criteria of what works and what doesn't. And that's why all physios are different in how they treat injuries. We just pick what works, what we're comfortable with describing works. And and we use it.
And you're understanding and happy with that being a neurophysiological and psychosocial intervention as a means of reassurance, which you mentioned earlier.
Yeah,
of
course.
Yeah, and that just gets them going. So the reason I'm being heavy on that question is especially in sports medicine, you've got people injecting seahorse placenta and, tickling them with all sorts of different interventions, and I know that happens, and especially when something isn't going to plan, then those things come into play, and so that talk of adjuncts does always have to crop up alongside all the other good stuff.
Yeah, of course it is, and yeah, I guess I haven't seen any seahorse placenta to date, but
you're missing out.
Yeah, and I guess you're barking down the tree of when do you stop, and I think what I'm saying is it's when you start to not feel comfortable with what evidence is out there to attribute what you're doing. And
then when you're, I think that's a really fair and nice line to have, leaning on your own judgment of honesty and autonomy and being a trustworthy and scrutinised clinician. I agree. But then also it can be, that hunch can be left to one side when it gets distributed out. So you can outsource some of these things. So you'd be thinking, well, I certainly wouldn't inject seahorse placenta, but there's a guy who works out of a very interesting clinic in Morocco who's doing just that. And so as soon as you make that, well, just see what he says, then that player is taken outside of the system a little bit. And so the line gets very blurry, doesn't it? So what's your position on some of the more out there things? And I don't necessarily mean in an evidence-based sense. Let's just talk about the feasible mechanisms of some of these things.
I mean, I think in any rehab, things aren't going to be straightforward. There'll be times where you reach a plateau in rehab and you're struggling to find that extra bridge which might take you to the return to play that you need to get this player back to, and the pressures on you are massive to get there. So I think it's always important to have something up your sleeve, which is a go-to. As soon as you run out of ideas for your patient, then the whole rehab process can completely stagnate. You need to have a go-to move, I always think. It's a case of when does that stop?
Yeah. I suppose with the complex stuff that's not going quite to plan, I just worry that if in the back of your mind you're thinking, well, if this doesn't start to turn a better corner, then essentially we do always have the option of doing some stem cells mixed with PRP, mixed with, and obviously I made up several other injectables, but I'm just meaning that would that not undermine the keeping it simple approach that you've otherwise lent on for the whole time?
Yeah, I think so, but I think the difference in our setting is you need to get a player back at all costs. So you need to always have something up your sleeve that you can move to. I mean, there are players that have been out to people like Müller-Wohlfahrt out in Germany and had Activig, Traumil and the likes injected and come back and carried on playing. And for them, it might have been that last final hurdle, whatever happened while they were over there, be it physiological, I doubt it was, but psychological maybe, to get them over that final hurdle. And if it worked for that player, then so be it, because they're back out on the pitch and that's what our job demands.
Right. No, it's interesting. It's a very difficult grey area, and that's a really sensible, pragmatic answer, and one I know is awkward to say, and I really appreciate you saying it, but it is something that I wonder in the future if people to take what Leicester City and yourself are promoting as a keep it simple approach and being recognising that is the meat on the bones and the other stuff is just small tinkering, often with psychology, then hopefully would it be fair for me to say that in the future we can anticipate that might get phased out as you produce results with less of that, what I would call nonsense? Yeah,
I guess so. I mean, I think it's as you say, the importance is to keep a core of what you fundamentally believe in and what you believe works and what there's an evidence base around. And sometimes, if circumstances dictate it in football, there is a need to venture out to some of the less evidence-based modalities or treatment options. But as long as you always come back into that core and don't lose sight of that, then that doesn't sit too badly with me.
No, fair enough. And I know you and I know your department well enough to know that you're not going to be going out to sending your players to witches and wizards anytime readily. And so I totally respect that as an answer, and you're certainly not the people I should be throwing stuff at. I just know that others are somewhat less, you could say, somewhat less ethical, and that is why I think these conversations are valuable. So thanks for engaging me on that. Now, you're heavily specialised in football, however, as you hopefully have demonstrated, very well read, very well reasoned with things. So if you were to see patients within an NHS private practice setting where time is finite, where are your priorities lying then?
I think what's good about the hamstring rehab protocol that I mentioned is that it sort of falls on a continuum, and it starts off with being injured, and it's a gradual progression that doesn't use thousands of pounds worth of equipment. You don't need a massive gym. You don't need a massive amount of physio contact time either. It takes an educational process, and then the rest of it would be patient-led. And I think working privately or in the NHS, that's a valuable thing. You'll be able to see your patient, and when you see them next week, they've carried on their rehab process on their own because they dictate it themselves. All that changes is the end of the continuum. For us, it's reaching those really high peak speeds. Can we hang our hat on that to let them return to play? Whereas in the NHS, they might fall a lot shorter down the continuum to whatever their end goals are, be it digging the garden or having a 5k park run of a weekend.
No, absolutely. No, that makes sense. But then you would be, bearing in mind what you've said is your core of recovery, then you'd be prioritising those things over the more, like you said, less evidence-based modalities.
It's like
they'd get squeezed out, wouldn't they?
It's like we said, what are the core principles? They're what you start with.
Yeah, and load management being at the heart of everything. And so, to wrap up, how do you think sports medicine will progress in the coming years? And how do you feel Leicester City Football Club is going to hopefully contribute to this?
Well, I'm lucky at Leicester in the sense that I work in a medicine and sports science department of like-minded staff who are always forward-thinking, never want to stop and admire too much what we're doing, and always open to new ideas. I think the important thing with sports medicine, both globally and for the individual, is to make the most of your learning opportunities. Treat every injury that way. What can you learn from it? What can you improve? What can you change to your prevention plan, if you were to call it that, to try and to alter your future experiences? And have more, I think in the future, particularly in football, I think more focus will be placed on the education side for coaching staff and management. I mean, we speak about who are the key stakeholders in injuries, and medicine departments have a massive role to play, but you need to be well in tune with your coaching staff and your management staff, because they're the ones who a lot of the time are going to dictate how long you're out on those pitches, what type of sessions you're doing, what type of intensity those sessions will be, and an education with management and coaches around what the effects of those sessions can be, I think are important conversations to have, and can help to modify risk and let them know that they can help to modify what they see in the treatment room and who's available for them to play their big games. We know through some of Ekstrand's work in the Champions League audit, he found correlations across the Champions League of managers moving to other clubs and injury rates following the manager, which might be indicative to say that particular training methods or structures of weeks that they bring with them have a key role to play in injuries.
No, for sure. And so with regards to what, I mean, how have Leicester been able to leave the egos at the door then and be as open and honest? Because you share an awful lot of your material, as you're doing here, as well as trying to engage with other clubs to try and make it learn from each other rather than it being the secretive industry that it has been maybe historically.
Yeah, I mean, I wouldn't like to speak for other clubs too much, but I think for us, all we do, we just treat physiotherapy for what it is, and as a profession, it's about sharing best practice as best you can, and we don't see why that would be limited to football. So we're quite open and honest, and just because we have a particular recipe, if you were to call it reluctantly, of how to rehab a hamstring, it doesn't mean that if someone was to take exactly what I've said and implement it in their football club, that they get the same results.
No, for sure. No, there's a bigger context around it, isn't there?
Of course.
And so with regards to the incredible things that Leicester City have done in a football sense this season, and how it's blown the lid off a a monopoly of big clubs and the idea of the little man and the underdog doing well. Now, it's fair to say you're far from an underdog now. It's been a proven success story that hasn't been a fluke. Now, could we recognise that perhaps that small medical department and the keep it simple approach, do you think that might be embraced, or does it depend on whether you're able to continue that despite your season becoming more complex next season with Champions League football, likelihood of better cup runs, etc.?
Yeah, it's as I said, everything's a learning process, and things for us are going to change next season. We'll have to deal with European football, our structure of the week, which we spoke about, our load management will have to be tinkered with. And it'll be a learning process. And, we're not scared to say that there'll probably be mistakes that are made on the way, and there's potential that there'll be a few casualties along the way in terms of injuries that we might have been able to better manage, but it's all part of a learning process, and as long as we can learn from those experiences, it's worthwhile.
No, I really appreciate that honesty. Now, if I was to admit, if I look into a crystal ball and I was to say, if you were to be able to maintain an exemplary record as a department, both medically and the team were to continue to perform at the standard that it is, or in and around there, and to become a force and remain a force to be reckoned with as you are doing on the football pitch, then I sort of anticipate it being a brilliant way of demonstrating to the industry that has so much money that it can be done in a simple manner, that there doesn't need to be a babysitter for every player that has his own personal masseuse, for example. And I do agree that depends as to whether you can keep that performance up, and that, because it would almost fall apart if you started to have a really difficult time of it with injuries. People would just look at it as saying that, well, the reason why the big clubs can't do what Leicester City have done is because they're different schedules. But let's say that didn't happen. Can you understand why I hope that as a vision, and do you like the idea that it could be simplified for the future?
Yeah, I mean, as I said before, our way of doing it is one approach, and we're not saying that the way that we do things is completely different to the way that other football clubs do things. Their schedules may be different, but they may be doing very similar things in the gym. For all we know, we don't truly know what other people's schedules are. All we're doing is giving a snapshot of what we do at Leicester.
Yeah, absolutely. No, that's great. And now, if the listeners wanted to find out more about you, about the department, about the club, then what they're doing to find out more?
Well, I'm on Twitter for my sins, so I'm at Simon Murphy 23 if people would like to tweet me. Or if people would like to send me an email, I'm simon.murphy@lcfc.co.uk, and I'm happy to respond to emails as and when I get a chance.
Yeah, of course. You're probably going to be busy in the next few weeks. All the best for...
Might set out of office.
Yeah, I can imagine. But I really hope that you every success in the coming weeks. Of course, with Leicester on the cusp of something glorious in world football. But also, thanks a lot for your time today, as well as for the department for endorsing and allowing you to come and chat to me. So, really appreciate it.
Cheers, Jack.
Thanks a lot. And that's a wrap. Hope you don't mind it being another long episode, but I'm sure you can agree there was very little there that we want to trim out. Simon and of course Leicester City are a huge example of what can be achieved through hard work and pragmatic application of evidence-informed practice, and recognising that although we can aim for things in the future, there is a here and now that needs to be accounted for. These players' injuries and of course the staff around them need to be managed in certain ways in keeping with their expectations, and therefore it is a complex melting pot of ideas and beliefs that I feel the medical staff, including Simon, manage very well over at Leicester City. We can all hope that their model is wheeled out. It's certainly yielding results, and they're recognising that simple can be made effective, and so I've got every hope that will continue. Huge thanks again for the time, as well as for feedback from all of you over the course of the last few episodes. It's been incredible what we're getting over on Twitter and Facebook. Please find us at TPM Podcast on Twitter, as well as the Physio Matters Podcast on Facebook. I'm at choose_health on Twitter, as well as I've got a new page under my name Jack Chew, just to avoid friend requests on the personal page. So that's over on Facebook as well. We're trying to do more through that. We've got some blogs coming out, as well as the Physio Matters team will be over at Cause Health Conference in 2 weeks' time, in which we're recording and documenting the whole thing, both in audio and on video. So look out for that. Certainly be peddled out on the social media front. We also have had an abstract accepted thanks to the hard work of Jack March, who's twisted my arm. I'll be dragged there kicking and screaming to the European Registry of the World Confederation of Physical Therapy Conference, which is in Liverpool, so come and find us there. That's over in November, so we'll be working up to that. Also, massive thanks to the International Physiotherapy Students Meeting, which was over in Portugal. I was over there with some students working over the weekend on workshops and a lecture that I delivered to them. Huge forward-thinking group of clinicians over on the continent that really don't get the exposure they deserve. Certainly a brilliant idea that I was exposed to that I wanted to let you know about, a concept called Physio Couch, which you can find on Facebook, Physio Couch. It's kind of like a couch surfing network for physiotherapists and physiotherapy students, certainly new graduate physios who want to experience different corners of the continent and might want to be able to share ideas both online and then in person if they wanted to do city swaps, etc. So certainly check that out if you're a new grad or a physio student. And we're going to be linking in soon through our student projects on social media with the future network of the WCPT. So keep an eye out for all these exciting projects. And once again, I have the honours of doing our cheesy sign out. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.